Now we will move on to the next important topic in neurological instrumentation, that is somatosensory evoked potential. So the learning objective of today class is that we will going to focus full on what is meant by somatosensory evoked potential and its basics, and we will have a different types of somatosensory evoked potential, that is upper extremity and lower extremity, and then also we will be focusing on what is the different electrode placement, okay, for especially recording the somatosensory evoked potential, and followed by we will be also discussing the different waveform analysis for the subsequent types. Finally, we will wind up with what is the different clinical applications which is there for somatosensory evoked potential. So before getting into the topic, first we will understand what is the problem of this people is facing, especially neurological disorders, and what is the needed, how come the somatosensory evoked potential is giving the solution for this problem. The problem is that the neurological disorders, as all we know, that it's something related to the sensory pathways. If we focusing on especially the sensory pathway, then we will have so many problems like loss of sensation. You may not have proper movement, like impaired motor function. So literally it affects one's quality of the life. So such neurological disorders especially need objective assessment methods to identify what is the problem, where is the problem, why it has happened. So that it is easy for doctors or clinicians to monitor what is the disease progression. According to that, they give the treatment decision and subsequent treatment also. For this problem and need, they have given a beautiful solution, that is a somatosensory evoked potential, which gives a clear objective assessment pathway of your sensory organs. You can have a real-time monitoring capability also to record where is the problem is there. It easily identified the disorder area, that is the malfunctioning area, and then we can do decision according to the disease progression, and also we can give a very good treatment discussion and treatment plans. So that is how the somato evoked potential has been evolved and come into the picture, especially in the hospital areas. The somatosensory evoked potential, the basic definition is that it is a type of techniques which is used to record the electrical potential which is being generated by sensory nerves, which in return in response to the external stimulus. Here it gives a very good assessment of your peripheral and central nervous system. So the assessment of central nervous system here is happening by giving some sort of external stimulus, and we are recording a response of action potential according to that. So here we will be giving the stimulus like a square waveform in the range of 100 to 200 milliseconds at the interval of the 3 to 7 seconds. The intensity is varies patient to patient. So 2.5 to 3 times per sensory threshold we will be giving, and the amplitude is like 10 microvolts. The main motto of this somatosensory evoked potential technique is that to diagnose the nerve damage, and you can have a different analyzing of lesions, especially in the central and peripheral nervous system, and you can have a different. You can easily detect different issues of spinal cord, and it very good treatment or very good diagnosing method, that is objective assessment method to find any disorders related to the central and peripheral nervous system. So there is a two types of somatosensory evoked potential. One is upper extremity and then second one is lower extremity. Upper extremity, for example, above the hip you are considering means then it is upper, and below the it is that lower extremity. So here I have taken an example in upper extremity, that is the medial nerve. Here lower extremity I have taken for tibia nerve. So here for a recording assessment, for doing the assessment of medial nerve, we have to next going for the active point for electrode placement. Here we are taking as a three placement. One is a brachial plexus, that is your collarbone. Second one is a dorsal columnar nuclei, and third one is like that is the back of your neck, and third one is active side, that is your sensory part of in your brain, that is the thalamocortical part or primary sensory cortex. These are the three active points where we are going to place the electrode to record the somatosensory action potential of median nerves. Similarly, for lower extremity, for example, tibial nerve, if you want to record the action potential in the sense, again you have to choose the three active site of area, that is the L3, that is the lumbar region. You have to focus. Second one is the thoracic region, and third one is your thalamocortical activity, that is your brain part. So lumbar, thoracic, and the brain part. Here we are focusing collarbone, neck bone, and your brain part, that is for upper extremity and lower extremity. Now we will move on to the electrode placement. So here electrode placements, as I said already in previous slide, it varies for two types, that is upper extremity and lower extremity, because upper extremity means that is above the lumbar part, and lower extremity is below the lumbar part. So upper extremity we have FZ, CZ under C3 and C4, that is for cortex, XZ for cervical, and FZ for your common electrodes, that is a frontal midline. That is the ERB point, cervical spine, and contralateral scalp. These are 3 points. The ERB points is your collarbone, cervical band is the back of the neck, and contralateral scalp is your the brain part. This is for upper extremity electrode site, electrode placement. Then for lower extremity, you have a lumbar, because in spinal cord we have a different segments, right? Starting from your neck, that is cervical, thoracic, and lumbar, cochlear, and sacral. So here for thoracic, lower extremity, we will concentrate from the lumbar, and then we have thoracic, and then primary sensory cortex, that is your brain part. So these are three electrode site for lower extremity. So at the end of that, you will get waveform as the output. You can see at the display. So as we discussed already in your visually evoked potential, here also we get the waveform in different components, different negative peaks, positive peaks at different seconds. So here the latencies matters, because the latency is nothing but the time taken for the stimulus to record the response or to give the response. That is what the latency, measurement of time. So here if you see any delay in this latency, we already have a standard values. Like if you having a particular stimulus at nth second, means it represents that particular area, that is ERB points or bracteal pluses points. So like that we can easily locate where is the problem is there, and what is the problem. So if you see the difference in this latency seconds, time seconds, then we can easily identify why the problem is there and where the problem is. So that is the very important outcome you can get from this waveform. That is the inference you can get from this somatosensory waveforms. So again, there are different components for upper extremity. You can see as in waveform patterns, that is N13 component, N20 or P23 component. So N13 component, it is the origin of dorsal column and cochlear. That is especially you can see at the cervical spine. And N20 and P23 component you can see as a brain part, that is thalamocortical radiations, that you can record at contralateral scalp. So if there is a latency, if you see here, it is been mentioned like 13 to 15 milliseconds for N13, and N20 20 to 23 seconds. If you are getting within this latency, means there is no problem. If it's going beyond, or if there is any delay in this latency, then we can easily identify based on the recording site where the problem is there. Similarly for lower extremity, you have the you have a L3 component, that is a lumbar component. That the origin is that nerve nutes of cauda equina, that is the area you can see in a spinal cord, that is the lumbar spine. The latency for this is 19 milliseconds. The clinical significance, that you can easily identify the integrity of lumbar nerves, where if you have problem, if there is any problem or not, that you can easily identify. So that is the next is T12 component of lower extremity, that is a thoracic, and P35 and N45 components, that is for thalamocortical, that is the brain part of your primary sensory cortex. So next we will move on to the clinical application of somatosensory. Its main thing is it can easily identify diagnosing the nerve damage, especially in spinal cord, nerve degeneration, and trauma assessment. And on the other side, we can also easily identify the different lesion types, central, whether it is central or peripheral, or you can have a specific pathway mapping with help of the somatosensory, and we can have a different lesion conditioning on different stages. We can have very good diagnosing of different lesion at the different stages. That is what main clinical application of somatosensory. And apart from that, we can you can also have intraoperative monitoring, that is post surgery monitoring, that is spinal surgery, neurosurgical procedures, vascular innervation. In that case also, we the SSEP is using very widely. Yes, thank you.